Okay, good evening again, ladies and gentlemen. Welcome to lecture 3 of the course in Child and Adolescent Therapy. Thank you all for coming this evening. At this time, if I could ask Mr. Nyame, who has been gracious with us for the last time since last week, if he could be kind enough to open in prayer for us this evening. Mr. Nyame?
Okay. Almighty God, we thank you that you have been able to assist us, oh God, direct us, oh God, so that we can start tonight, even on time. We ask, oh God, that you continue to help the technology to maintain connectivity for everyone who is in this chat room. We ask, oh, that you guide the proceedings from here on in, and that we will all benefit greatly from this lecture. In Jesus' name, amen.
Amen. Okay, so ladies and gentlemen, I'm happy that we are able to make a connection this evening without any hitch, and I know we are. I in fact received several emails of concerns regarding the connectivity, and had spoken to Mr. Nyama to see how we could help. However, my understanding from students was that the last evening's chat, some students had some questions, and I would like to use this time for questions to be fielded for what you need, or some notes that were not you had not fully had the notes and were not clear. Now is the time to do so. But let me just lay down, I think, which can help the process, is that sometimes when I'm my trend of thought is flowing, and if I'm interrupted in the middle of the lecture, I will forget what I have to the thought, and I have to go back and rephrase. So what I'm going to suggest is that I'm going to lecture, and I'm going to ask after a certain time. I'm going to field questions. And if I say, "Are there any questions?" that means that I'm inviting you to ask questions as is, because if that way, then people will be able to there'll be more flowing and more things that are in sync. So at this time, I would like to have the questions fielded right now. Mr. Nyame?
Yes, I'm here.
Am I to click on that link to get the questions, or people will just ask me the questions now?
No, those that are on YouTube now wouldn't have any questions, I would expect, because they were in the live chat the last time.
Okay, but the students who are now on the live chat, are there any questions? Are there any general questions or comments?
Well, Hello Jean wanted to ask a question about the group project. So I don't know if you want us to do that first, and then we can ask the question.
Yes, let's do that first. I mean, I know several persons that asked about the group project. Just to underscore and that this, again, it's a child and adolescent therapy course, rather. It is not really, we do psychopathology, but we split. So this class is an emphasis on that. So even though I had said given the instructions for the project, what I meant was I want you to take a note. I gave a number of treatment approaches we'll be studying throughout this course. Mm-hmm. Take one, research it, but take a disorder from the disorders of childhood, or the neurodevelopmental disorders, as in the DSM-5. Look at one and tell me how are you going to treat that disorder. So the emphasis is more primarily on treatment, although you will tell us what the disorder is, how it came about. Is it that so you'll probably give me a little bit about the disorder itself, the etiology, etc., all that. But the primary emphasis is on treatment. Is it clear?
So therefore, Dr. Mack, if it is that you're choosing, say for instance, an ODD or something like that, would you want us to give you the diagnostic criteria of it, as well as?
Yes, you can do that. Okay. You can do that. You can explain what the disorder is about.
Okay.
It's either the disorders of childhood, which really new developmental disorders. It's no longer this, because that's DSM-4, but this DSM-5 specifically talks about neurodevelopmental disorders. And I want to go through them this evening because I think it's very important, and I think it will help you in how you're going to tailor your presentations.
So therefore, is it that we only should be using neurodevelopmental disorders, or can we use other disorders?
Any disorders of childhood towards children.
So
one disorder that's depression is geared towards children, anxiety is geared towards children.
So once it's this depression that the child or adolescent occurs within a child or an adolescent, it is okay to do that in the project.
Yes. Okay. But I wouldn't expect you to give the antisocial personality disorder for a 9-year-old. Or paraphilia. Those are adult disorders. It's a child adolescent class.
Conduct disorder or
yes. Go ahead.
So you told Hello Jean a child, but we could use an adolescent like a 14-year-old or 15-year-old.
Yes, I'm sorry. When I mean childhood, I meant I should have underscored. My apologies. Children and adolescents.
Okay.
Under 19.
Okay.
Thanks.
Or I should say under 18. Under 18.
Under 18.
So either I expect a child case or a teenage case. Because it's important that we understand exactly. But basically, your role in this class is to pay special 80% of your present should be on treatment. Yes. Is it clear? I don't care how you do it. I don't care how you present it. All I want to see how you use this. The treatment.
Treatment plan.
That's all I'm interested in, because this is the treatment approach and a treatment plan together.
But we haven't learned a treatment
approach and a treatment. Yeah, but what I'm saying to you is we have learned it. No. You haven't learned it. No, hold on. You haven't learned it yet. But what I'm saying to you, focus on the treatment approach. Let's not go to the plan yet because you haven't learned it. So in order for you not to be confused, I want you to research the treatment approach or intervention, not a treatment plan. It's going to confuse people.
All right. So Dr. Mack, let me just ask you for clarity. So in the approach, you gave us a number of points that we should use to prepare the paper. So you have the history and so forth and so on. And we need to follow those guidelines as you have given.
Follow the guidelines as I have them there. I know that there was a concern from students about, and maybe I need to go to it if, I know there was a concern about the actual, what was expected of the paper, of the presentation. Am I correct? Somebody had a concern about that?
Yes, we would love to know. Yes, Dr. Mack. But before you go there, Dr. Mack, can I just ask one other quick question from the listing? Yes. You had also variation of / on the technique. Exactly what it is that you're asking.
Let me see what you're talking about. I don't know. I have to. What page on the syllabus?
8.
8. Okay. Hold on, please. Just give me a moment.
Thank you.
Okay, I have it up. Where
that's the second to last guideline.
Okay. Variation, in other words, what I mean here is sometimes the technique, has the technique been modified over a period of time? For example, there are a lot of revisions for some of the techniques. Has it been used? Has it been modified? Can it be used with other? What can it be used with? Can it be used with depression? Can it be used with eating disorders? Can it be used with other disorders apart from the one you selected? That's what I mean.
Okay. Because we kind of got a different meaning, but okay.
What was the meaning you got?
I want to say that, Dr. Mack. So okay. But anyway, what we were thinking, at least what I was thinking, what the thought process was in terms of variation on the technique was whether or not there were other techniques that you have the technique, but there were some other techniques that kind of surrounded it or spun off from it.
Yes, you can. But what I'm saying to you is that I don't want you to go off to the deep end, that you'll get lost.
Okay.
In the because it's a topic that you have to control yourself. I mean,
right.
You're dealing with children. It can be used. I mean, for example, transactional analysis can be used with adults. It can be used with children. It can be used with primarily teenagers. But you have to be very, very key, because you will be so much. This is for children. You have to focus on the population that you're treating. The target population is child or adolescent. You can mention it, but you don't want to go too much overboard.
So really, just stick to the whole idea of whether that particular therapy that you have chosen has been modified. So it might start with
modified, or has it been, what is that? What else can it be used with?
Okay, so
but you mentioned that, but I don't want a detailed elaboration. What I want focus is how you're going to treat this particular disorder of childhood. So you can use a case, you can use role play, you can use whatever.
Okay.
Are there any other questions? The people on YouTube, do they have any questions that they need to field?
I'm not seeing any. I'm not hearing any from them. Seeing any from them yet?
All right. Are they able to? Or is it the group chat? I'm not seeing it on my on my screen. If I type, can they see it, Mr. Nami?
No, they can't see if you type in the live chat. They can only hear what you respond to them. All I do is just copy their questions and put it in this live chat area, and you can respond to them.
Students on the YouTube format, if you have any questions, please send the questions to Mr. Niame that I can answer them, please.
Well, they just have to enter them in the chat, and I'll copy it.
Okay.
Have to send it.
Any other questions, ladies and gentlemen? This is not the time I'm devoting.
All right. So the question.
Yes.
Okay. Questions that I have, Dr. Mack. I don't know if anybody has anything else about the group project. If not, yes. Okay.
No. Okay.
Any questions about that?
Go ahead, Michelle.
All right, Dr. Mack. For the last class, you had mentioned something about protective factors, and I don't think I understood clearly what the protective factors were. Marshall, you had a question to ask? Marshall?
Yes, I had a question.
Ask the question then.
Oh my God, so sorry. It just have food in my mouth. My question, Dr. Mack, is on the second group assignment. Is it that nearer to a particular time you're going to give us a case for us to work on?
Yes. Well, yes. The aim is to also, and I'm glad that you mentioned that. The aim of this class was to give people a case in the classroom setting, but with the problems we're having, I don't know if that's going to work. What I'm thinking is that I'm going to give the case anyway, and people go in your groups and plan it, and then we see if we can present it on after it's done, because to do it in the class is going to be hard. I don't know how we're going to do that.
But Dr. Mack, we still, in the class setting, still need to go through cases with you so that we can understand what is what. I know,
but we have to find a way to do it with people on YouTube and people on the live chat. I'm trying to figure a way to do that. But we'll do what we can. I plan to start the cases on Monday.
Okay.
Try and go through some cases.
Okay.
I probably will have to send it quickly that you can look at it, and then we talk about it.
Right. The only thing I was going to ask you, Dr. Mack, when are you planning on sending us the actual case so we can start looking at it?
Let me send it. I have one that I'll send. Mr. Nyame, when do you suggest we do that? Let me ask the administrator. When do you suggest we do that?
Send a case?
But when we send the case, though, what are we going to do with the case after you have sent it if we haven't learned what it is that we're supposed to do with this particular case?
Well, you wait for instructions.
I beg your pardon, doctor?
I'm saying you will wait for instructions. I'm saying to you that we will. Okay, the case, you students don't need to get too anxious. We will. All right, so we wait on you then, Dr. Mack. We wait on you. We will do the cases. We'll do a case or cases in the class that you understand. I want you to, because there are certain conditions and guidelines you need to understand working with children, which is a bit different than working with an adult. So I want you to bear with me. Let me just go through some. Hello?
Yes, Dr. Mack.
Yes, Dr. Mack, I'm here.
No, I'm not hearing. Are you hearing me?
Yes, Dr. Mack, I'm hearing you. I think Michelle is also hearing you.
We're all hearing you.
Yes, Dr. Mack.
Okay, I'm trying to get it. Hold on, please. Yes, I'm trying to get this connected in my head. Much better. Yeah, what I'm saying is that I will be sending the cases and I'll be able to teach you what is it I want when you look at a child case. I don't think we can do it tonight, but I'll try and do it on Monday, first thing. Okay. So I'm going to send you the case for you to look over. Okay. And that way you can familiarize yourself with the case and be prepared to ask questions when I talk about it. How is that?
That sounds quite fine.
Okay. All right. So not what I'm asking on.
I was asking a question, Dr. Mack,
about the lecture. Let's feel the questions from last lecture to clear up any misunderstandings or confusion. I need to clear your obfuscations. So
spell that word, Dr. Mack.
Obfuscation. Obfuscation. That's a word I learned in high school, you know.
What? You're a bright girl. Dr. Mack. Let me start with my questions first.
Go ahead.
The first thing that I had a little issue with is that I wasn't quite grasping the whole concept of protective factors. You had asked. Okay, go ahead.
Finish your sentence. I'm listening.
You did mention that the protective factors was it aligned to the Rotter's the 6 Rotter's, what you call it, factors?
Yes.
Or was there one from it that it was aligned to?
No, Rotter's factors, Rotter's indicators.
Indicators, okay.
Okay, Rotter's indicators. So don't be confused.
Okay.
Rotter's indicators at 6 major
indicators. I'm fine with the Rotter's indicators.
However, in terms of understanding the risk, when you see a child, most children will be going through several risk factors in terms of their behaviors, their history, etiology, their family dynamics. And I talked about 4 distinct factors: risk. And I talked about the predisposing. I talked about the precipitating, I talked about perpetuating, and I talked about the protective. Okay. And I remember saying that for the protective factors it's one of the primary factors within childhood development and behavior, because it underscores where it is within an attachment process, that of the caregiver. It doesn't matter what the caregiver is or who the caregiver is, but what it does is that it provides environmental stimulation, it provides emotional bonding. Environmental stimulation and emotional bonding. This protective factor, this is a condition. Remember, we looked at the street boys. Let's put that into perspective, where the boys were on the streets. They had was there protective factors or an absence of protective factors with the street boys that you saw on the clip? Was there any protective factors?
No, Dr. Mack.
Okay. So go ahead.
No, because there was an individual that mentioned that the older boys would hold them up and take away their monies and stuff. and he has to go to the police station. So that would be their only reprieve. Right. So there was no real protective factor there.
Okay. So protective factors then is going to include the role of the caregiver or the child's parents. When we talk about protective factors, we're looking at the role, how the parents, how the caregiver creates a condition for the child to have three things. One, I said safety. The child must feel safety. So in that environment, the child must feel safe. 2, security.
Stabilization.
And stability. In other words, those are the 3 factors. Now, let me say this. I did say if the homeostasis of the family dynamics is, could some people mute your mic?
Ramona, mute your mic.
Because I'm hearing the feedback in my ear, please.
Rowena, sorry, mute your mic.
What I'm saying is, what I said was that if the bearing on the absences of these 3 conditions,
you're saying something about homeostasis, doctor.
Yes, if the family homeostasis has been compromised, meaning the stability of the family structure has been compromised. In other words, there is no stability. The child feels unsafe. The child feels insecure. You are going to have an attachment problem.
Okay.
And not only that, the child is going to feel there is going to be a disruption in the developmental continuum. In other words, there is going to be destabilization of the developmental process.
Okay.
For example, the child develops separation anxiety, as in case of a divorce, abuse, trauma, gunfire. Child sees gunfire. The child will start feeling afraid. So children can develop, when there is an absence of those 3 conditions, they can develop several disorders of childhood. One can be separation anxiety, where there is an anxiety around the absence or the fear or loss of a love object or the parents. 2, child can develop depression. 3, child can develop a generalized anxiety disorder. So these are types of disorders that can happen when the protective factors are compromised. Let me just say that within the protective factors, let me just clarify again further. Within the protective factors, that aspect of it, listen carefully. Children when you're treating children, you need to look at 2 major processes, which are 1, internalization of behavior. 1 is internalization of behavior, and 2, externalizing of the child's intrapsychic fears. 1 is internalizing behaviors, and 2, the externalizing of the child's intrapsychic fears. Now, for the former, which is internalizing, the child tends to, based upon this is now for internalizing. The child is there is what is known as an introjective process. It's an introjective process where the child will, or the teenager will take on within themselves fears, anxiety, depression. So the disorders become acts out within. So the disturbances are within the child. So a anxious child can incorporate is because the child is internalizing the fears from the environment. Internalizing means that the child is incorporating or introjecting events from the environment. They are reacting to it. They are reacting to it. They become, so if it's a divorce, disruptions, parents left, parents are fighting, the child sometimes can incorporate those fears. So it's 2, externalizing means that the child is going to act out. They're acting out the disturbance within from the environment. They're acting out their perception of what's happening within the environment. They're acting it out. So a child can have ODD, or opposition defiant. They can have conduct. The child can have depression. The child can. So the behaviors are externalized. People see it. So in an externalizing behavior, it is seen outside of the home, in school, wherever, in the child's in the ecological system. So you see it. Let me continue with under the protective factors. Under the protective factors also, I'm hearing some rustling. It's under the protective factors. I think I lost my train of thought. It will come back to me. I'm sorry. I lost my train of thought. Any questions so far? I'm trying to remember what I wanted to say to you, which is important. But any questions so far? Let me open up. Any questions?
Yes, I have a question. I got bumped off, so I was sure you, Dr. had given like a practical example of what protective factors.
You're on twice, Nardia.
Yeah, she's
Okay, you're good now.
I keep getting bumped off. Sorry.
Okay.
I was saying I have a question.
Go ahead.
Right. I was saying I wasn't sure if when I got bumped off, if Dr. Mack, if you had give some examples of protective factors, so I can understand that.
In terms of what? In terms of what?
Well, you said that protective factors. This is how the caregiver create a condition so that the child can have safety, security, and stability. So I just wanted you to
No. What I said was the protective factors themselves are creative conditions, which provide. What's that?
Yes, conditions such as what?
No, these are the protective factors are conditions that the child is based upon the matter of the conditions within the home where the caregivers will create an environment. So there are two processes. One is the caregiver creating the conditions in terms of how they work within the home, and 2, the conditions within the home. So if in a home that is stable, the child will feel safe, secure, and there will be stabilization. Is it clear?
Okay.
So therefore, Dr. Mack, so based on that now, based on that example, you're saying the protective factors then are factors that the parent and the caregiver and whomever else is in the home would put in place to protect the child within the home, and absence of those can lead to trauma and depression and all those JDs and everything else?
Not only the parents, the factors are that that it is the condition of in other words, if the family homeostasis is stable, if you have a stable homeostasis or a stable structure, where the child sees predictability, the child sees consistency, the child sees what? The stable. It will create these conditions because one, the child will see, okay, mommy will be there every time. So every time I expect to be, daddy and mama will always be there. So, which in children, it is more, I did try to say before that it's linked to the child's cognitive abilities. Okay? In other words, a child with sensory motor abilities looks at object permanence. So in other words, there has to be an establishment of object permanence in children. So then, what I'm going,
So then, Dr. Mack, just for the benefit of maybe other persons who are on YouTube listening and other persons who, so then, for example, a protective factor could be the fact that the child has a good relationship with both parents, or the child has a good relationship with an aunt.
Yes, absolutely.
Okay.
Yes. And this protective factors is based upon not just the parent, because what I also want to talk about is that the protective factor, in other words, children have certain, the children grow within the child's development is based upon the matter of this developmental continuum. So the parents or the caregivers create the conditions. The family homeostasis provides and hones the parent's ability to create those conditions. And thirdly, children within the child's dynamic themselves, temperament is also important, which I want to give you now. Temperament. Because when you see children,
what's that now, Dr. Ma? That's in relation to what?
Temperament, I'm still on the protective factors. I'm still elaborating on the protective factors. I'm saying
notes on that?
Continue with the notes now, please. That I'm going to give you the notes that in a child, when you're going to work with children, one of the things you need to be aware of is a child's temperament.
Okay.
What are you seeing in front of you? Every child that you see come to you is going to be different. No one child is the same. They're going to be different. So it is what the child is also bringing within that protective process. So what is temperament? It refers to the child's basic disposition. The child's basic disposition, which influences how the child responds to situations. Let me repeat. It is the child's or teenagers. When I say child, I mean teenager. I mean basic disposition, which influences how the child, he or she, responds to situation. Temperament is affected by heredity or heritability. Temperament is affected by heritability. It is very, very heavily weighted on personality development and adjustment. It is heavily weighted on personality and adjustment. Let me give you an example. When I work with children in play therapy, there are some children who will, children in terms of their personality style or their temperament, some children will, They're tentative, they stand in the door and they look inside and they look at you. Some of the children will run past you and they start playing. That's how the child responds. So children have different ways of responding to the environment. That's temperament. And that's what you need to be aware of when you're going to work with children. Their temperament. It will give you an idea of the element of the protective factors. Is the child clinging all the time to mother? Something is not right. Is the child shy? Is the child have too much of a boundary problem? Every stranger the child wants to be friendly with. Another red flag. So temperament is important.
So Dr. Mark, if the child is clingy, would that be a bad sign as a protective factor, or would it be a good sign? Based on what?
Well, children somebody making a comment?
No, I was about to say that would basically show that the child is insecure.
Why? How so?
Sometimes they become clingy because they fear the fact that maybe they've had a parent or somebody who has left them without explanation and taken a very long time to come back, or don't ever come back. And so they become clingy to the one that stays with them with the fear that they might leave them someday.
Give an example.
For example, let's say two persons, mother and father, usually live together. Problems in the home, separation occurs.
Yes.
Sometimes the child might become clingy to the mother with fear that mom might get up and leave them one day.
So you're saying that clingy behavior means that the child has had some developmental trauma. Is that what you're saying?
Yes, in some cases, in most cases.
One of his parenting style has to do with it.
Explain, Ms. Michelle. Explain, please.
Sure. Like the parent, how what they say to the child. For example, you go out, you sit with me alone, don't go anywhere. Don't talk to strangers or anybody, just stay with me. So when the child goes out, they cling to mommy.
Okay. All right. Let's ask the question. What do you think? When is a red flag when a child is too clingy? Is there a red flag to note when a child is too clingy to parents? That the child has difficulty separating from adult caregivers.
Let me ask this other question, Dr. Mack, to answer that one, because there has to be some degree of clinging. I might think a child is clinging because I'm seeing them out in like at a birthday party, and instead of interacting with other children, that child might decide that they want to be beside their mother. No, I might say that child is clingy when probably the child is just shy and not fully integrated into playing with other children. So how do we know that a child is clingy or not? So it would depend on our perception of what clingy is. So in a situation like that, I would not think that it is a red flag in that particular scenario.
Well, I get the point, but this is a distinction. That there are two distinct. One is stranger anxiety in younger children, and one is separation anxiety. Two different things. Stranger anxiety is a normal behavioral occurrence. In a sensory motor child, birth to 2 years, because children develop separation anxiety. It peaks at between 8 to 12 months, and then it disappears after 2 years. So if a child sees a stranger for the first time, the child tends to cling. However, if, for example, little Johnny has difficulty separating from is 7 years old, has difficulty separating from his mom after an incident of something happening, and the child starts clinging, that's a problem. So the child starts to fall. So that's because that. So in other words, we have had a stage of cognitive development. We have had a stage of development where there was an introduction of a developmental trauma to regress the child. So in a separation anxiety, you're looking at regression, where the child is going back couple years in terms of their behavior due to a traumatic event. So in a separation, it's a developmental trauma the child has endured. So one is innate developmental, which is stranger anxiety, which is normal. The other one is an induced trauma. Is it clear?
Very clear.
Anybody from YouTube, Mr. Nyame, any questions from those people from YouTube? I'm not hearing no questions. Anything?
Dr. Ma.
Yes.
Dr. Ma. Why would being too friendly cause red flags if, say, the parents are very they are very I don't know, outgoing or something? Why would there be a problem if the child is friendly?
Okay, it depends on what friendly is. When you explain what you mean by friendly.
I mean, he goes to everybody he sees. He has no problem with going. You see somebody's mother, he might stretch to them or something. So he stretches.
But if the parents were, let me ask you this question: if the parents were upset, would the child go to strangers?
Well,
I would doubt it.
Oh, does it depend on the age also?
Well, it depends on the nature of the attachment. That's what I'm going. So I'm looking at. I'm going through attachment issues because these are important to underscore and teaching for this course. That what I meant to say was that when I say about overly friendliness, I'm talking about children who don't seem to have it. They are not able to regulate their behavior and impulses. So when you have children who have gone through a severe of attachment problems, they become overly friendly and they tend to walk away. Sometimes children get kidnapped because they lure them with candy. Every stranger they see, and so they're not able to regulate. They're thinking about, oh, danger! Don't go to this man. It's going to take you away and hurt you. That's what I mean.
But then, Dr. Mac, how would that be a breakdown of the caregiver or the parental role?
Well, it depends. Well, in terms of the nature of attachment, the protective factors and attachment are very, very highly linked, because a child's healthy development, childhood disorders, or the emergence. I talked about the evolving and resolving. The evolving of childhood disorders is based upon the nature of the parental attachment and the parental style of parenting.
Okay.
Very, very. So you can look at it. You can, when you see children coming to you, you can see what's going on in the home. You know what's happening. So, for example, I'm jumping the gun here. But one of the ways of seeing into how the parents interact is watch how does the child sit near to the parent or the child sits far from the parent? Is a child cuddling with the parent when they are being interviewed? So these are indicators or signs of what's happening in the parental in the home. All right. Any questions? I'm still not hearing anybody from YouTube.
Dr. Mann?
Yes.
I see where Allison said something. She said parents might teach children with fears or impulses as well. Therefore, the child might not understand certain boundary levels. That's from Allison on YouTube.
Okay. Ask her into what what is she talking about where that's concerned?
And she said the child may end up being too friendly or too shy. I think she's relating to the whole fact of the child being friendly. So she's explaining why they may become as friendly as they are.
Read what you said again, please. Read what you said again.
He says parents might teach children their fears or impulses as well. Therefore, the child might not understand certain boundary levels. The child may end up being too friendly or too shy.
Okay. Oh, I see it now.
You see it? Okay.
Yeah, I'm seeing it. Thank you. She's asking the question, is it correct to think that the school could serve as a protective factor? Let me throw it out. Is the school the primary function of rearing children? Let me ask the question.
No.
Robert,
no, but they can help.
Should be.
Dr. Mac, somebody else is saying.
I think it could serve as a protective factor.
In other words, what's the function of a protective factor? Is it the school? Is it the school's responsibility to rear children?
No.
But children spend most of their day at school. Children spend most of their days at school, so I think there are certain things that the school with children, and I think it would serve as a protective factor as well.
Okay. Let's hear it.
The first thing, Dr. Mac, are you seeing Robert's comment?
I'm going to have to click on the chat to see what he's saying.
Just read it.
He's saying that school should now be. He's saying that school should. If I'm understanding what he's writing, he's saying that school
should play a protective.
No.
He's agreed
should get involved.
Should serve as a protective factor.
He said school should be. Yeah, I guess he's saying it should be part. Is it what he's saying?
He's saying it should serve as a part of the protective factor.
A part of the protective factor.
Oh, okay. But picture a teacher in the reality of Jamaican education for 30-odd students who are teachers. With one teacher in a class of 30-odd children. Is that right or fair?
Not fair. Not fair.
Alison says that she thinks school is a secondary protective factor.
Yes.
Okay.
Right. Because even when you go to teacher say, so the school and teacher does have an impact on their lives.
School has an impact for the first.
Okay, be careful about and I don't want to go Bronfenbrenner's ecological model. Okay, I'm sorry.
Alison is saying
I'm seeing it. I'm seeing it.
Great.
I'm seeing it. I think the school is a protective factor. Now, it's not the school's responsibility to. However, in light of what is happening with our children, school should be. So people are saying. So there are people are saying that. What I'm getting is that people are saying the school should take up that slack that the parents are lacking. Is that what I'm hearing?
I think that's the point.
Is that what I'm hearing?
I think so.
Hello?
Yes, based on what's happening now. Yes, Dr. Matt, that's what you're hearing. And yeah, based on what is happening now in the society as it is.
Yes.
But ideally, as Alison said, it really should be a secondary protective factor.
With the home as the primary.
With the home as the primary, but based on what is going on in this land right here, so now, where the parents, as we saw in the video the other day, she's saying that she's so young that her children don't even pay any man or listen to her. They might listen to the teacher at school if they do go. So yeah, the system has changed somewhat. So that's basically what is being said.
Okay. Well, I think that I can share people's concern about the school being the protective factor. However, we have to be very careful though, because the children they're there every day, but they're there only for 8 hours, and so the school has certain function which is to educate the child. Are you with me? Are you with me?
Yes, we are.
Yes.
Huh?
Yes,
I was thinking that education would be a protective factor. Hello?
Explain what I'm hearing you. What do you mean by education?
For example, the street boys that we watch the video. I think a protective factor that was missing is the fact that they were illiterate. Because, for example, one of the boys said that he could look at the girl and know that she has HIV or any other STDs. So I really think that the school in that light serve as a protective factor. I could be wrong, but that's
there's no right and wrong here. It's more clarifying and looking at what protective factors are. For the most part, we have been looking at protective factors in terms of the family homeostasis and the family structure. But
there's
in the light of that,
there's a comment on what you on that as well on the chat.
Also, the church should also operate. Is that what it is?
Yes.
I see two. Totally unfair for a class should have 30+ students. Also, the church should also operate as a protective factor. Mr. Barr seems to think that way. What do you think, ladies and gentlemen? I throw it out to you. This is a class. This is the class of thinking and to coming up with things because you're going to be working with these children in Jamaica. What do you think? Is your role, even as potential counselors of children and are you going to be an adolescent? Are you going to be? Is your role a part of the protective factor? You're part of the church. Do you think that your role is to protect these children? If we look at what the definition is I gave you, is that your role professionally?
Yes, Dr. Mark.
In what way?
This is when you're going ahead, Victor.
Go ahead, Annie. Go ahead.
I believe that our role. Sorry, you're going ahead, Victor.
The role of the caregiver. Role of the caregiver. It's the role of the caregiver. Who is online? Go ahead.
I believe our role should be there as to protect them in light of giving them safety, security, and stability. Because when we as counselors interact with these children, they will form a sense of emotional connection with us, and this will play out in their lives when they go back home. So I strongly believe that we as counselors also serve to help them to develop this emotional bonding and to give them the simulations that they need in the environment so that when they actually go home, they will be able to transfer what is learned at school with us as counselors, dealing with them on a day, weekly, whatever basis it is. So I believe that we serve also in helping them with this connection and bonding, serving as a protective.
How would you, okay, let me ask you a question. Would you have a 5-year-old client in your lab?
Oh, no.
Would you have a 5-year-old client? Would you touch, I mean, so there are, so and so we have to look at the matter of protective factors with very, very scant ethical lens.
Yeah, okay, yeah.
So, because with children, it's, even North America, they're very strict. And so even when you're, for example, when I have to renew my malpractice insurance or license, they ask you, have you ever been, you have to take certain courses, or you have to report, have you ever been censured by your association for inappropriate behavior? So we have, I'm bringing this out and for you to think about it. in that we have to be careful as counselors when you look at the ethics of working with children, that we have certain professional boundaries. Do you agree?
Yes, Dr. Mack.
So you will have a 5-year-old. So you will have a 5-year-old on your lap, or touching a sexual abuse child or teenager. That may send a signal or message, and you have to be very careful, extremely careful, very careful.
Dr. Mack.
Yes.
Latoya is saying that she believes it is a part of our role from YouTube.
What is a part of our role? I see it.
Being a protective factor.
What is the what? I think I'll type. I hope she can see. Mr. Nyami, can she see the?
No,
okay.
Just ask her the question, Dr. Mack. She's hearing.
Okay. Tell me what is it? Why is it a part of our role? What is the role? What role are you referring to, Mrs. Cameron? What role are you referring to? We haven't touched ethics yet. You see, I'm opening up the can of worms now on one subject. This is what is your role?
She's typing it, Dr. Mack, and Kojo's pasting it in. Okay, all right.
So let me continue though. We were on temperament, and we didn't veer off. We veer off, but it's important in talking about this. Let me so we talked about what temperament is. So let's just look at what temperament is. So these researchers are extremely important. Thomas and Chess. 1977, 1987. They did a similar research in childhood literature, and they came up with 9 basic temperament categories.
I'm sorry, Dr. Mack. Thomas and who? Chess?
Thomas and Chess. Chess.
Oh.
CHESS.
What's the year, Dr. Mack?
1977.
Okay.
1977 and 1987.
Okay.
Very important study for you to be aware of in working with children.
What was the study now? Dr.
Mack? They came up with 9 basic temperamental qualities in children. And they are as follows. Listen carefully. They are as follows. 1, activity level. Activity level. 2, rhythmicity.
What's that, Dr. Mack?
Rhythmicity.
Oh.
Rhythmicity.
Dr. Mack, where come those words from?
Not me, it's research.
Okay,
3,
Dr. Mack.
approach/withdrawal. These are types of temperament. Approach/withdrawal. The next one is adaptability. Adaptability. The next is threshold of responsiveness. The next is threshold of responsiveness. The next is intensity of reaction to situations. And I see a question which I'll answer when I'm done. Intensity of situations. Quality of mood. Very carefully. Quality of mood. And the last are distractibility and persistence. The last, distractibility and persistence. Those are 9 developmental qualities. Now, under those qualities are 4 basic subtypes of temperament, or categories, I should say, of temperament that you need to be aware of. And I'm going to give them to you. But before I do that, let me answer the question. There is a correlation between school failure and delinquency. Eileen, in case of abuse or neglect, knowing such information would be pertinent to children or Sissoko, etc. The U.S. Department of Health and Human Services suggests that protective factors are conditions or attributes in individuals, families, communities that, when present, mitigate or eliminate risk in families to increase health and well-being of children. Therefore, we are protective factors, but the home is the primary factor, she's saying. That's what she's saying. Any comments to what she said?
Dr. Mack, those were those were 3 comments. One was from Eileen first, then the next one.
I see that, and one from Latoya.
And then
one from Alison. Yes. Okay. But I'm asking the students, the students who are live, any comments on what they said? Any comments? Remind me what Sissoko is again, please. What is Sissoko again? Remind me. Is that what is Sissoko?
The issues with children and so sexual abuse is and so on.
Okay.
It's the agency, Dr. Matt, that deals with children who have been abused and so forth.
Okay, wonderful. Do you agree?
I remember what the acronym means.
In other words, I think we can just sum this up. That I agree that we, in a sense, are responsible for protecting children. Why? Because if you see, it is your responsibility. If you see a child having marks on the child's any mark, you report it. Am I correct?
Right.
Yes. So in a sense, you are protecting the child. However, you have to be. There have to be some boundaries of professionalism.
Right.
You can't be too over-friendly with children. You have to be very, very careful.
That's where ethics come in, though, Dr. Matt.
That's where ethics come in. Absolutely. So yes, I agree that we all are responsible. We all are extensions of the home in terms of
within the bounds of ethics.
Oh, within the bounds of ethics. Good. So we are clear on that then.
Yes,
right.
So let's continue then with the categories of temperament. One is easygoing children. So when you work, you're going to notice children who are easygoing. These are even-tempered people. They are easygoing in their mannerisms. Even-tempered. They have good sleeping patterns, eating patterns. They adapt to new situations. They adapt easily to new situations and people, and they're generally positive children. The second is difficult children. The difficult children are irritable. They withdraw from new situations. They're irritable, withdraw from new situations and people. They have unpredictable behaviors. And also negative moods. So difficult children are irritable. So basically you will have some children, especially so note a child It's even worse when children are depressed. They're very, very difficult to treat because when a child is depressed, they normally become very irritable. I had said that there were 4, but it's actually 3 categories. So I'm going to give you the last one. The third and final category is slow to warm up children. Slow to warm up children. They are inactive and negative in their moods, difficulty with adjusting to peers, and to adjusting to new situations. So along with the difficult children, the slow to warm up can have adjustment issues in adulthood. They are prone to adjustment problems in adulthood. So be careful of a child who comes to you and they,
Dr.
for
Mark?
example, yes.
Are prone to what? Are prone to what?
I beg your pardon?
Along with the difficult children, these children
I said along with difficult children and slow to warm up children. These 2 categories, they are the most where the adult, when children become adults, they have difficulties with adjustment in their lives.
Okay, thanks.
And I was saying that watch for children, children who are depressed, or children who have behavioral problems where they hurt animals. These children will have serious problems later on. So for children who have difficulty hurting animals, or they hurt children without any remorse.
What about
that's a red flag.
What about breaking off the dolly head?
A red flag.
In Dr. Mark?
That's a red flag.
Oh, you're answering. Okay. Thanks. Dr.
That's it's a very, very serious red flag. So these 2 categories of children, I'm giving you now another. We're going to move to a different paragraph, but this is under the same temperament. I'm not done. The 2 categories of children I talked to, well, actually 3. This researcher by the name of Kagan, very important in child psychology, Kagan. And Kagan's research in 1989 talked about what is known as behavioral inhibition. Behavioral inhibition. Behavioral inhibition in that it looks at behavioral inhibition it's a behavioral process. It's a behavioral process which is linked to the level of physiological activity in children. So when a child, for example, is exposed, children are exposed to unfamiliar situations.
It's linked to the what in children, before you move on? Behavioral process linked to the?
it's linked to the physiological processes. So behavioral inhibition. So children, in terms of temperament, especially so behavioral inhibition means that the child has had several. There are behavioral characteristics that are linked to the how they react in terms of their body functions. And the research looks at children, particularly who are faced with very unfamiliar situations. Unfamiliar situations. There will be increased heart rate. This is just the research I'm quoting. With increased heart rate, changes in blood pressure, and pupillary dilation. Primarily the two categories of children I talked about, temperament, the difficult and the easy to warm up. These are known as inhibited children. They are inhibited.
The difficult and easy and slow to warm up.
Yes, they are. These children are inhibited.
Okay.
They are inhibited. The child who is less inhibited are the easygoing children. The child or the children who are less inhibited are the easygoing children in their temperament.
One other quick comment, Dr. Mack. When you said physiological processes, such as bodily functions in unfamiliar situations, increased heart rate and so on. I understand what you're saying. I'm making a comment. I understand what you're saying. I'm just making a comment. Would you also put in there like your favorite thing, encopeces and enuresis and all those kinds of things?
Absolutely.
Would that be a part of it?
Okay. Absolutely. Okay. Absolutely. Very good. What a touch of what I called unmitigated brilliance.
Lord have mercy.
Very good.
Thank you, ma'am.
All right. So, continuing with Thomas and Chess. Thomas and Chess developed also, and you need to know this, a goodness and fit model. Thomas and Chess, same researchers or the investigators of children, developed a goodness of fit model. Goodness of fit. And it says, and I'm giving you what it means, that there is a degree of match. There is a degree of match between the parents' or caregivers' behaviors. Right? And their child's temperament. There is a match with the child's temperament and the parents' behaviors. And this will contribute to how the child develops in later life. That's called the goodness of fit model. All right. That's it so far for protective factors. Are there any questions, please? Any questions? Is it clear, everybody? Are there any questions to ask?
The question I have, earlier you mentioned something about the internalization and externalization. I wanted to know if one would lead to the other. If the child would experience the internal properties first, and then it will come out in the external ones, or it's just separate and apart.
Okay, I'm not too clear what the question is, Miss Mayor. Could you repeat again, please?
Earlier you mentioned about the two major properties in the initial stage when you were saying something about the externalization of the behavior and the but I wanted to know if one would lead to the other. If the child will start internalizing the environment having the fears and anxiety first, and then it will come up now in the disturbances, acting out, the oppositional defiant behaviors will start coming out after they started.
What I mean is that some children either do one or two of the other. Either they internalize when they get depressed, so they take what's happening in the environment within themselves, and they begin to worry. They begin to have interprecies. They have depression. They get anxious. Some children, instead of internalize, they externalize that problem until they act out. They act out what's bothering them in the environment. The internalizing child will take what's happening in the environment and take it within them, and it affects them instead. Is it clear?
Okay, yeah, clear now, because I thought that like it's separate and apart.
Yeah, you can have both children doing that, but for the most part, you have a child either internalizing that behavior or they externalize it.
Okay.
Both children and adolescents will do that.
Okay, all right, then thanks.
Any other question? Any other questions, anybody, before we go on to something else? I think it's pretty crystal clear. All right, so I am going to go over briefly the DSM-5 disorders for children. In the last course, I know several persons had not done the course, but I'll do my best. In that we looked at the role of the DSM in child with disorders, and I did say, that some of the child with disorders have been changed considerably. And what I'm going to be doing is just briefly going through the disorders that you need to be aware of, and it will be a good opportunity for you to look at the disorders in terms of what's required for this course. So basically, the child with disorders, under the old DSM-TR, it used to be called disorders of infancy, childhood, and adolescence. It's now no longer in that category, but it's called overall neurodevelopmental disorders. Why? Because there is an impact on the central nervous system on childhood development. There is an impact of the central nervous system or brain processes on developmental on the childhood development, and there are quite a number here, which I will. It's on the. It is on the in weeks 2 resource material, which it talks about. I have it up on my screen. So there are several headings, which are intellectual abilities, communication disorders, autism spectrum disorder, attention deficit, specific learning disorder, mood disorders, other developmental disorders, etc. Mr. Nyame, is there a possibility this could be put up on screen, or the students can go to it after the class? Is Mr. Nyame there? Unmute your mics, Mr. Nyame.
Yeah, I'm here.
What I'm asking, the DSM-5 childhood disorders. I am reading from my screen, and I wanted the students to see it. But I'm saying it's on the week 2's. It's on week 2's resources, I believe, on the DSM-5. Can it be put up on the screen, please?
I'll try now. Just continue reading, and I'll try to put it up.
Okay.
Please.
So basically, ladies and gentlemen, what I want you to know about when we're looking at diagnosis, what is diagnosis? What it is that is different for child, and understanding what diagnosis is. Now, note that that all disorders, let me say this to you, from adulthood starts in childhood. All disorders has origins in childhood. There are some disorders that continue on to adulthood. There are some disorders of childhood, or some neurodevelopmental disorders, I should clarify, continue on to adulthood. I also want to say that there are some disorders from the adult stream that manifest themselves in children, but they are resolvable. In other words, they resolve. For example, depression, anxiety, some of the symptom disorders. Also, there are some disorders that are that has a direct link to brain processes. Brain processes or brain trauma. For example, intellectual disabilities, communication disorders, autism spectrum, motor disorders. So there are a number of factors that can cause a number of childhood disorders. Now, there is a specific defect called teratogens. Teratogens, Teratogens. Teratogens.
Dr. Mark?
Yes.
What
are
is
they
the
up?
name of the file?
It's called DSM-5 Table of Contents.
Okay.
Just put it up on screen for me, please.
No, I'm trying to find it. I didn't know exactly which one.
It's in the DSM-5. I believe it's in week 1 where it says DSM-5 document. There's a folder with all the DSM in it. It's in there.
Okay.
That they can see it, and they can ask questions if they need to on the disorders of childhood.
It's actually week 2. It's week 2.
I didn't see it in week 2.
Is it?
Yes, it's week 2.
It's in week 2. I mean, I just.
I don't see any table of contents. Where is it?
Okay. It says it says DSM-5 table of contents, DSM-5 classification.
I don't see that.
I can't go in right now.
That's okay.
All right. Can I send you by email?
Yeah, you can. And
all right. Just bear with me. Give me a moment, students. Let me send it to him, and then I get back to you.
Dr. Matt, what does it start off by saying? There's something here that says Child Psychopathology Seminar DSM-4.
No, that's not what I'm talking about. No. It's in a folder with all the DSM-5 information that I had from there. I don't know. I'm sending it to him, but he can put it up on screen for you to see it, because
Bojo.
Yeah.
In week 2 on the unit 2, there's a heading called Diagnostic Statistical Manual. Then you have the folder of DSM-5 under it.
Yeah, but I don't see anything like that in the DSM-5 folder. I haven't seen it, but which one of them? Which one of the
I think it's the one that says DSM-5 New Psychiatric Disorder. Is that it, Dr. Mack?
Hold on, let me see what it's, because I had labeled it. So it's New Psychiatric Disorder. Yes.
Right. DSM-5 New Psychiatric Disorder.
Very good. Thank you.
What is the file name?
New Psychiatric Disorders.
What is the file name, Michelle? Okay, I see it. Okay.
Okay, just put it up for me. Let me talk to the students about it.
I'll try and put it on the screen.
Yes, that way I can see it, because I while he's putting that up, ladies and gentlemen, let me just say that that with the change of a new, just to rehash and refresh people from the last course briefly, that with the change of the DSM-5 in 2013, the child with disorders have been totally radicalized. So in other words, you now have all the disorders of childhood are now known as neurodevelopmental disorders, and you have a number of categories of disorders. Is it up yet, Mr. Nami?
Not yet. One moment.
All right. So basically, under the DSM-5, the neurodevelopmental disorders. So you no longer have, for example, people who are familiar with the DSM-4 TR, for example, would have known that mental retardation would have been one such child with disorder. It's no longer, mental retardation is no longer the case. What you have is in its place a category called intellectual disabilities. So the child with disorders are important, especially in child and adolescent therapy, is because it's the gateway of behavioral disturbances under the developmental spectrum. And so the DSM, so the child with disorders are more seen in the DSM-5 as categorical in nature. They're seen in categories. So when you're looking at the DSM-5, it uses the categorical approach. The categorical approach, that is, that behaviors are on a continuum. Behaviors are basically on a continuum, and signs and symptoms may not necessarily meet the diagnostic criteria in the DSM. So,
may not necessarily meet what, Dr. Matt?
I beg your pardon? It may not necessarily meet the diagnostic criteria in the DSM. So what I'm saying is that childhood disorders are very complex. You can't find a ready-made cookbook for every disorder. Children they're complex. So a child may have one of everything. A child may, for example, have a communication disorder, or they may have ADHD. So in children, most of the disorders in children are known as comorbidity. In other words, you will have a primary and a secondary diagnosis. Comorbidity. 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 That is, you have a primary and a secondary diagnosis. So let's say, for example, a child who has depression is likely to have anxiety. A child who has trauma is more likely to develop separation anxiety disorders. A child that has intellectual disability is more than likely to have ADHD. Any questions so far?
Yes, I have a question.
Go ahead.
I was just trying to, as you mentioned about depression in childhood.
Depression,
I'm trying to figure out how easy is it to detect a child who is depressed. What are some signs I can look for?
All right. Okay. What were you thinking about?
Well, I know that for adults,
yes.
You know, when they're depressed, they tend to be withdrawn and they don't find anything pleasurable. But for a child who's unable, and they may be able to express themselves that they're depressed, but for a child who is not really expressed his or her feeling, it's kind of, I think it's a bit I
think you're breaking up. I'm not hearing you very clearly.
Can you hear me now?
No, you're breaking up.
All right,
much better.
What I'm saying is, unlike an adult,
go ahead.
Right, unlike an adult who can easily and readily express feelings, able to express exactly how he or she is feeling. So my question is, how can you tell when a child is depressed? What are some things to...
Hello?
I think she's asking Dr. Mark.
Oh my goodness. She's gone.
Yes. I think she's asking what are some of the signs, what signs you could look for in order to determine if a child is depressed.
All right, good question. Okay. Now, depression in children is different than depression in adults. And I think the question people want to know is whether or not what are some of the symptoms and signs you can see in a child or teenager than you can see in an adult. Am I correct? Is that what she's at? Oh, she's back.
Right. Yes.
Is that what you're asking?
Yes, doctor. That's what I'm saying. Yeah, that's what I'm.
Okay. All right. Now a mood disorder. In the DSM-5, there used to be children in depressive symptoms in children. Now, whereas an adult cognitively can express or verbalize their depressive mood, for example, adults normally are able to verbalize what they are feeling. Children are not able to do that cognitively.
Yes.
So, whereas you can...
It's 6 years now.
Hello, I'm hearing. Hello, what's going on here? I'm hearing. Okay, so whereas in an adult, where in terms of their mood, they can articulate, and you see it in their affect and their mood. Children tend to act out their depression. For example, a child who is irritable, they fight, they're irritable, they regress, they may have enuresis and caprices, and for those persons who may or may not know, enuresis is bedwetting, and caprices is soiling of the underwear, or they may have night terrors. They may develop separation and they may cling.
Stop it now. Oh my God.
What's going on? Hello? Am I talking rubbish or something? People? Hello?
No, Dr. Mac, continue, sorry.
Okay. Yeah, so mostly you find that there are, so children will behave behaviorally. Children are going to behave behaviorally in a mood disorder. It's called mood dysregulation disorder in the new DSM-5. Mood dysregulation disorder. So what a child will do is that they're going to act out their depression. It's up.
It might be a little.
Have I answered?
Yes, you have answered. But you have answered, but I'm just thinking that it might be a little bit technical, because you mentioned that a child will get irritable, but I'm just thinking of a child who is just not well, physically, and is irritable as a result of what is happening to him or her.
When you say a child is not well, if the child is sick,
if the child is sick, and the child is not irritable because he or she is sick. So the thing too is not because the experience, it might be able for you to easily detect depression in children. But for me now, who has never really been able to detect that, it might be difficult for me to just look at a child and determine that that child is actually depressed.
There are ways of knowing how a child is, because you have to know how to interview the child to know what to ask. So if when you're doing when we get to treat, when we do interviews with children, you may ask a child, you may have to rely very heavily on the parents.
Okay.
So the interview with the parents will give you an indication, because children can't express, they're not able to express themselves. And, and on the website, there is, did I say website? I meant on the Moodle platform. There's an interview with children, yeah. So I will go through that and help you. But basically what you'll do, there is a skill in asking a child certain things. So for example, you will ask, you always interview young children in the third person. You never ask a child a close-ended question and say, what's wrong with you?
Right.
You ask a child, I know Johnny is feeling very scared right now. Can you tell me what he's feeling? You'll get more information than saying, tell me what's happening. Child will answer you. So you always, when you're interviewing young, you always answer in the third person.
Okay.
And answer the question right now without, did that answer the question? We'll do that more next week.
Clearer, much clearer.
All right. We have the information. You're welcome. You have the information on you have it up. I'm trying to get it up. Can we put can you adjust to the first page for child with disorders, please?
Okay, I will.
Let me.
Where is that? Which page is that?
Okay, the first page, and I'll tell you, and I'll guide you. Now, is everybody seeing the handout? Are you seeing it? Are you seeing it?
No,
yes.
Seen it.
Okay. Now, if you see, well, you see the neurodevelopmental disorders, and note how many under that you have a number of categories. So let's go to page 2, please, that we can see everything. Page 2. Okay. Continue. All right. So these are the categories of disorders on the neurodevelopmental. Autism spectrum is one. Why? Because autism is based upon a brain disturbance. Attention deficit disorder is a brain disturbance. Before that, ADHD used to be under the old DSM-4, used to be under the behavioral disruptive disorders. Now, so these are categories of neurodevelopmental disorders that you need to be familiar with. Then we have specific learning disorders that deals with now learning disabilities in children. So you may have specific learning disorders, maybe reading, writing, and the fun reading, writing. Let me see, reading and arithmetic. Those are it's known as our maths. These are known now as specific learning disorder. Then you have the motor disorders. So you may have children who may have a stereotypic movement disorders. So a stereotypic movement disorders is a brain. It's like Huntington's or Parkinson's, but it's more where it's in the basal ganglia of the brain that deals with movement. And so movement is within the control of the of certain structures in the brain. Like I said, the caudate nucleus that deals with Tourette's, that controls Tourette's. So most and the putamen, substantia nigra, but so all these, so most of these disorders are brain based, and for this you may have to have medication for these types of disorders. Continue, Mr. Nyame. Continue. Now, under the schizophrenia, you can have child with schizophrenia in children. I mean, so about maybe 1 to 2% of children will have schizophrenia, but it's not a common disorder in children. That's why it's under the adult. Continue. Okay, you can stop. Under the depressed, somebody asked a question about depression in children. Now, I talked about, there was one that was added called the disruptive mood dysregulation disorder. You will find this kind of disorder in children. A child who comes into you, they have behavioral problems. They're referred from the guidance counselor because they're behaving, they're fighting, they're not learning, they're staring to space. This is now known as a disruptive mood because there is a combination of a mood problem, which is depression, and behavioral problem, which is more behavioral in nature. You may have children, you may have disorders with children who they're depressed. And someone asks about what happens when a child is depressed. So you may have a child who has a major depressive disorder. So children who, and I want to say this, that children who commit sometimes end up killing themselves. And I'm saying this to you, listen carefully. necessarily mean that the child wants to necessarily die. But children who tend to commit suicide do so because of the nature of their cognitive thinking. So they think, so if I go there and hang myself, hopefully I'll stay on the clothesline and somebody will notice me as I'm crying out for help. But sometimes when you go up there, it means that if you hang yourself and you're dead, you're dead. But there are, again, when we get to this depression in children, when we talk about that, how to work with a child with depression, I'll give you some telltale signs of that. Let's continue and go through quickly. Anxiety disorders is common in children. Separation, selective mutism. I treated a child a couple years ago who was selectively mute, and this child, I recall, was mute because his parents had divorced, and he was very, very angry with the father. And I remember in play when the parents brought the child, the mother brought the child, and he didn't want to come into the playroom. He was very difficult, and so I was talking to the mom in the playroom and decided to watch him, because I had to determine what type of temper this child had. So what I did, I tried to engage and talking to the mom, getting the feedback. So I decided to put some toys out the door because he wouldn't talk. He wouldn't say a word. He wouldn't come in. So I left. So I was talking to the mom and I was watching him at the corner of my eye. And I noticed, so I saw a foot coming in from the door. And I saw a toy sailing into the door. And I heard, so I ignored him. I was talking to the mom. Then suddenly I saw a whole box of toys running into the room, and I saw the child slowly coming into the room. Ignored him. Then I heard again, I said again, so I said, okay, you want to come in? So he came in and he had his hands like this. So I said, so what I decided to do in terms of dealing with selective mutism, just as one example, is to say, okay, seems like to me you're very, very angry. So I want you to, I know you don't have to talk. Mom is here, we can talk and we can see what's happening with you. So when he did a play, so when I do play therapy, I'll show you some play therapy things that I did and how to interpret that. But basically what happened in terms of the play, we had a dollhouse, and so what he did was that he created a scene where he had a house that was chaotic, and Dad left the house, or he took some human figures. So you could see in the play or in the dollhouse where you could see the splitting of the family. He put Father in the oven and slammed the door shut. And he had Mom in somewhere where she felt safe. So as I was doing that and noticing, I was trying to look at the dynamics of what he was doing with the play. And so I asked him, seems like little Johnny is very angry with Dad. So he was able, so even with play, play is where the child is able to develop or play out their internalized fears externally. And so he was able to create for me what he was experiencing internally within play. So that's just one example of, for example, work with a selectively mute child. Continue, Mr. Nyame. Substance, you will see in teenagers a number of substances with teenagers. Teenagers with panic attacks, extreme anxiety in teenagers. And working with teenagers is pretty difficult too, because unmute your mics, at what stage of cognitive development is our teenagers? Unmute your mics. What stage of cognitive development are teenagers? Unmute your mics. At this point in time, you should know that. At what stage of Piaget's cognitive development are teenagers? I don't believe this.
It's gone to sleep.
Unmute your mics. Unbelievable. The formal operations stage.
Oh, formal operational, yes.
They can be centric. Oh, really? You knew.
We just had a slight delay in memory. We know.
Slight delay in memory, but my memory is always sharp to remember things.
Realize.
Okay, there is also obsessive compulsive disorder. So look, so with the DSM, you're going to find some childhood disorders manifesting itself in some of the other disorders. For example, you're going to look at children who are going to they're going to hoard. Hoarding disorder is an anxiety disorder. It's a compulsive disorder. Trichotillomania is hair pulling. So you will have a child who is extremely anxious, can pull their hair. That's also where you'll find some of these disorders. But what I want to know that primarily, the childhood disorders, you will really see a child with hoarding unless it is an attachment problem. But most of the disorders you'll find are in the childhood, like you have anxieties, you have your learning problems, you have your ADHD. Continue, Mr. Nyame, please. Okay, now, as I said, the DSM has changed. Now, under the reactive, the attachment disorders are deemed now under trauma and stressors. So these are the differences in DSM where this is concerned. So a reactive attachment disorder is a childhood disorder. It's more attachment problems with children. Children can have PTSD. They can have adjustment disorders. They can have a disinhibited social engagement disorder. Or they can have a dissociative disorder. Not identity disorder, but a dissociation disorder with a child. So abused children can disassociate. Children who have been abused, both children and adolescents. Continue. Continue. So again, you're going to find that children, a child, for example, who has separation anxiety disorder, can develop phobias. So let's say, for example, a child, when you know when a child is anxious, when they start to, an anxious child generally tends to have physiological problems. So anxiety in a child is more physiological in nature. In other words, it's more bodily. They start to have aches, they have pains, they have stomach ache, they have headaches, they don't want to go to school. It's because it's a conversion reaction. They can't articulate their feelings, so the body tends to take on that anxiety. And so they experience anxiety as stomach ache, headaches. Continue. Feeding and eating disorders. So for people who want to, like you can stop now. Pica is a child who, for example, this is also a child with disorder. The child may want to eat dirt. They may eat insects. They may have, teenagers may have anorexia nervosa. These are problems mostly of teenagers' behaviors. The feeding and eating disorders. Continue. Of course, under that you have your elimination disorders. Enuresis, which is bedwetting. And let me say this for enuresis. There is a comorbidity, as I said, in a primary disorder. So a child can be enuretic, but they can also have a mood disorder. So enuresis can be a manifestation of depression, or it can be a manifestation of a trauma. And caprices is soiling. So this is more dealing with when a child is very angry or a child is traumatized and they have lost control of their bodily functions. I'm not seeing it, Mr. I think it's disappeared.
It just chipped off.
It's okay. It's okay. Is it okay? So what we are seeing then is that of all the categories of the DSM, some child disorders spread across the wide gamut. Is it clear? Is it clear?
Yes, Dr. Mack.
Is it very clear? As I said, this is not a DSM-5 class. It's not a psychopathology. It's just going through.
Yes, Dr. Mack.
Okay. All right. Let's look briefly at diagnosis in children.
Diagnosis what, Dr. Mack?
In children.
Okay.
Now, the word diagnosis comes from the Greek meaning to distinguish, to discern, or to decide. The word diagnosis comes from a Greek term meaning to distinguish, discern, or to decide. It was first used by Hippocrates. The Greek physician. It was first used by Hippocrates, the Greek physician. Diagnosis has a number of functions. Diagnosis has a number of functions, of which are one. Clinicians can talk about cases from a common perspective. Clinicians can talk about cases from a number of perspectives. Number two, it facilitates the collection of data, empirical psychiatric data. It facilitates the collection of psychiatric data. Three, is a must or a key ingredient in treatment planning. You cannot treat children without a diagnosis. It doesn't happen. It will be illegal, unethical. You have to have what you're treating. It is essential or a key ingredient in treatment planning. And four, can be used for scientific comparisons. Can be used for scientific comparisons of cases and how to treat them. The child disorders of the DSM-5, I'm continuing on the diagnosis, constitute what is known as a mental disorder. Constitute what is known as a mental disorder, and it can, so a mental disorder is as follows. A mental disorder, that is for children. We're talking about children specifically. And the DSM-5 disorders are mental disorders. It is a clinically significant pattern. Clinically significant pattern of psychological, clinical significant pattern of psychological and behavioral symptoms and signs. Let me repeat, psychobehavioral symptoms and signs. That is, let me explain that. Just listen before you write. That in children, basically what you're seeing is that the child is the symptoms. The child's symptoms are primarily behavioral. You can write now. The child's symptoms will be primarily behavioral in nature. And the psychological process are based upon innate impairment and disturbance.
Dr. Mark?
Yes.
Yes. Sorry, the child's symptoms are primarily what in nature, Dr. Mark?
Behavioral. In nature.
In nature. And the what? Can you finish the sentence for me, please?
And I said that, Mr. Nyam, I'm having a feedback.
Hello, Dr. Mark?
Sorry, Dr. Mark.
Can you I'm getting a feedback when I speak.
No, it's not anymore. It could have been Michelle, something with Michelle, but she's okay now.
Oh, okay. Okay, what I meant to say that that basically when you see children, you don't have to write, I'm just making a comment. When you see a child being referred to you, the problems are behavioral in nature. They manifest themselves behaviorally. So defiance, withdrawn behavior, they're fighting, those are behavioral disturbances. However, if it's psychological, what you're seeing are manifestations of the child reacting to the environmental stressors. And so that's why it's known as psychobehavioral. And so what you will see as a sign, what are signs are what you are observing in the interview with a child. Is a child sad? Is a child fearful? Is a child having difficulty with making eye contact with you? Those are signs of psychological distress.
Sorry, Dr. Mark, I don't want to stop it because I think you have gone beyond what I was going to ask, so I can't catch up at the point. You had said the child's symptoms are primarily behavioral in nature. And
yes,
what?
Yes.
What came after that?
And I'm saying that
You might not remember. Is there anybody who picked that up,
please? No. What I said was that, and therefore, but the psychological aspect, of it is that it's of signs and symptoms are related to the stress or impairment in the child.
And the psychological aspect are
related to the stress or impairment in the child. That's a sign. So let's say, for example, Johnny was referred to you because of fighting, bedwetting.
Sorry, Dr. Mack. I beg your pardon, Dr. Mack. Please bear with me. You were talking about symptoms. You said the child's symptoms, but you know you're talking about signs. So let me just get the symptoms part clear.
No, I said the symptoms are primarily behavioral in nature.
And then what?
And I said sign.
Somebody go ahead, please.
And the psychological process are based on the manifestation of the stress and impairment in the child.
And the psychological,
process are based on the manifestation of the stress and impairment in the child.
That's what I'm asking.
Is it clear? Let me give an example. So I'm saying to you, a child's been referred to you, meaning all of you, with symptoms of acting out. The child is defiant, angry, withdrawn, and behaving in ways that are acting and not studying and not paying attention at school. What would be the behavioral manifestation? Let me just see if I can put this in that you can understand. What would be the behavioral manifestation?
Repeat the scenario again, Dr. Mack.
Johnny, who is 10, has been referred to you for an assessment and for treatment. History of defiance, withdrawn behavior, fighting, temper tantrums, anger. What would be the behavioral manifestation?
Fighting and temper tantrums.
Yeah.
Fighting and temper tantrums?
That's the behavioral.
That's the behavior.
Okay. What would be, so in other words, the behavioral manifestation such as fighting and temper tantrums
and withdrawal.
Yes.
Those are behavioral. That's what, in other words, that's what the child is in other words, that's acting on. That's actually externalizing behavior. Now, in terms of the impairment, so how would you know that there's a disturbance in the child's in psychologically? What signs will you see?
Maybe the child is not getting good grades, or if
psychological.
Yes.
The child will be sad.
Sad,
withdrawn.
Those are signs to you.
Okay.
I won't tell you that. You see it. You're seeing it.
Yeah,
the parents will tell you. The parents will tell you that he has been withdrawn and sad. Those are signs.
You can see them.
Clear? It's clear?
They're obvious. Okay.
Is it very clear, ladies and gentlemen?
Very clear, Dr.
Yes, Dr. Let's continue. There are. So we look at what the functions of diagnosis. Now, diagnosis has several dimensions, and I'm just going to underscore them here. I hope, can we continue for a little bit more? I'm still awake, and I'm
Like half an hour more, Dr. Man.
Like
about half an hour more?
Yes.
Okay.
Yes. So it can be, we're going to look at in children, one is the biopsychosocial, 3 dimensions. Biopsychosocial.
functions and dimensions are the same, Dr. Mark? Because you have
no. These are dimensions of, in other words, I talked about diagnosis has several functions, but I'm talking about dimensions of diagnosis.
Okay. So do these dimensions come
totally different? Totally different.
So do these dimensions come under dimensions come under the functions of diagnosis or not?
No, they don't. I'm giving an.
Okay, so you scratch that out then.
Yeah, sorry.
Okay.
I'm sorry.
You started out with that, Dr. Mack. You started with that.
My apologies. What I call a senior moment of my articulate success.
Of your brilliance, a senior moment of your brilliance.
No, I don't know if it's a senior moment of my brilliance, but I'm talking about that time. The wine got to my head. See, I'm drinking some wine here and it's got to my head.
Don't drink anymore, Dr. Mack, please.
Okay.
So several dimensions.
Biopsychosocial. The developmental and the temporal. Biopsychosocial, developmental, and temporal.
Oh, so it's just three, Dr. Mack?
Three basic.
Okay.
Yes.
Developmental.
We are going to be studying.
And temporal.
Yes. We are going to be studying a number of these within this course.
Okay.
But let me just quickly give them to you, please. Bear with me.
All right, Dr. Mack. So these are three basic dimensions.
Yes. For the biopsychosocial, it's a comprehensive look at the child, at the entire function of the child within the social context. It's a comprehensive look at the child or teen or whatever, and teenagers. When I mean teenagers also within the social, psychological function, cognitive function, emotional, and within the family context.
But Dr. Mark, how is biopsychosocial cognitive?
Because what do you mean? Why is it cognitive?
I mean, I can understand why it is social. I can understand the psychological aspect of it, but the cognitive, is it because you're saying bio?
But biologicals ensure that you're studying the brain process of how children perceive their environment. So when you're looking at the biopsychosocial, you're looking at the child's ability to perceive his environment and function within it. Children don't perceive reality the way we adults do.
Right.
Right?
That's right.
So that's why it's important. It's more comprehensive. You're looking at the overall study of child development within this model. So it's almost like a model of understanding children in working with them.
Oh.
So for example, and I mean there's a lot I can say, but for example, you're going to look at, for the social, you're going to look at family structure dynamics for the social. School and occupational adjustment. These are important in working with children. You have to understand what's going on. Peer relations are important. in the social under this model? For the psychological, in explaining that, you're going to look at communication problems, if any, learning difficulties. Children who don't learn, for example, are going to have behavioral problems. Let me repeat. A child who has difficulty learning will have behavioral problems. Am I right or wrong?
Right.
Am I incorrect?
You are right, Dr. Mack. It's one of the risk factors.
Very good. Very good. Anybody from YouTube? Any questions? I'm not hearing from the people from YouTube. Do they have any questions? There's also, yes.
Just a quick question for on the function of diagnosis.
Yes.
You started with one clinician, but I didn't get that sentence. I don't know if anyone else got it. They can discuss cases from, and then I didn't get anything.
Oh, that was the first one that says diagnosis allows clinicians to discuss cases from a common perspective.
Okay, thanks.
Allows clinicians to discuss cases from a common perspective.
Thank you, Dr. Mack.
Are there any questions so far under the biopsychosocial model? Is it clear? In other words, what we'll be discussing is primarily discussed is the biopsychosocial model. It's more comprehensive. So even you will be exposed to that intake that I created. You'll be looking at it and learn how to do an intake with a child. Is it clear so far?
Yes, doctor.
All right. So let's look then at the developmental dimension. Let's look at that, please. Are we ready?
Yes, Dr. Mack.
Yes, Dr. Mack.
Okay. Now, under this developmental dimension, you are going to have to understand the developmental process of children. Children go through a life cycle of development. And this dimension looks at that life cycle in terms of chronological age. Let me repeat. This looks at the life cycle in terms of the chronological age of children. So would you treat a 3-year-old as you treat a 17-year-old teenager?
No, Dr. Mack.
Why not, Mr. Chiano?
Because of the difference in their developmental stages. For instance,
what level of Piaget's development would you find a 3-year-old, Mr. Chiano? What stage is that?
I think that's three.
That's what?
I think that should be under
what do you call the stage, ladies and gentlemen? What do you call that stage of Piaget's stage for 3-year-olds?
Pre-operational.
I need a glass of wine to wake me up. Very good. Pre-operational. Very good. Very good. Yes. So basically, then, so you're looking at chronological age, stages of cognitive. In other words, what I mean is that this dimension looks at the stages of the child's emotional and cognitive development. The child's emotional and cognitive development. And I'm continuing. Comer, C-O-M-E-R, 201. Comer talks about 4 guidelines. 4 guidelines. 4 guidelines. Comer?
What is Comer?
I didn't hear that. You're breaking
Comer.
up.
Is Comer?
Comer 2001 provides 4 guidelines, same under developmental. 4 guidelines for evaluating a child's behavior.
Okay.
1 is deviance. Deviance. This is determining the degree that a child's behaviors is considered to be deviant from the norm. Deviance is 1. Determining the degree that a child's behavior is considered to be deviant from the norm. So in treating this child, you may want to look at observations in the classroom or through testing, psychological assessment. Two is dysfunction. Dysfunction. This is the impact of the disorder on a child.
Can you repeat that, Dr. Mack?
It's in a dysfunction under Commerce guidelines for evaluating behaviors. It is looking at the impact of a disorder, child disorder on a child's behavior. For example, the impact of anxiety on a child's functioning, the impact of depression on a child's functioning, the impact of a traumatic episode on a child's functioning. So there's deviance and there's dysfunction. The third is distress. And you also said the question.
Dr. Mack?
Yes. Go ahead.
Is that the 4 criteria for abnormality?
What? Where are you getting that from?
Sound like the criteria. I just want clarification because that sounds like the
well, of course, yes.
criteria of normality.
Well, this is under the developmental.
Okay.
Probably, yes. Don't worry about that. I know what.
Developmental.
Yes.
Okay.
Yeah, I'm under the developmental dimension. I'm saying that you need to ask us the question that there is distress when the child's behavior impacts others. There is going to be distress both ways when the child's behavior impacts others, such as peers and or adults. Distress. So Johnny's ADHD, Johnny's hyperactivity is impacting the teacher who is frustrated and the children can't learn. Distress. And lastly under that is danger. 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 And this is to determine if the behavior places a child at risk. Determine if this particular disorder, be it conduct disorder, oppositional defiant disorder, depression, places the child at risk. Is he or her a danger to himself or to others? Are there any questions? I mean, the temporal is it's a little bit longer than I thought, so I may have to have that until Monday to go that over quickly and then go on to treatment. Are there any questions? We have talked about two dimensions of, we talked about the developmental and we talked about the biopsychosocial. Are there any questions? Temporal we have touched, it's going to be a little longer than I thought. But are there any questions?
No. No, Dr.
Any
You had started a point on under the, can't remember what the heading was, but you had mentioned the teratogens. I don't think you had actually
yes, and I apologize. I think I had a senior moment again. Yes, I need to have a glass of water. Need to have a glass of water before I go to bed.
Teratogens around there.
Okay, what I said was, let me just give you what it means. What I said was that it is important because you see, one of the things that you need to understand is that children are impacted by brain processes, and these biological functions impact behavior. So, let's say, for example, you may find a child who is referred to you. Let me give you an example. Who has difficulty, cannot learn, who cannot focus, who cannot read, who cannot write. What do you do with a child like that? How would you treat a child like that?
Testing.
What else? What kind of testing? What kind of testing?
Well, I don't know which of the psychological testing, but you test them to see their mental ability, I guess. Or cognitive, some cognitive tests or mental tests.
Assessment. Okay,
right.
but before you even go to that, if a child comes to you who cannot...
Oh, you could find out from the mother if there was any, for example, anything happened to the child at birth.
Yes.
Like, I know that
if they smoked or took alcohol or did any kind of thing that would affect the fetus and therefore cause some kind of brain
problem. Yes. Lack of oxygen can affect the fetus as well.
Yes.
Was the child born preach birth? Preach birth, or how long was the mother in labor, etc.
Yes. Good. So then you understand then that when we look at a basic intake, these are important to ask parents, because you want to know when you combine all these dimensions of models of interviewing children. You're looking at the biopsychosocial, you're also looking at the developmental, you're also looking at the temporal. You want to know, Johnny can't read, why not? So you ask the mom, did you have, pregnancy is important with interviewing, because you want to know whether or not this child's behavior is due to a developmental trauma, pregnancy. So a mother who was pregnant and the child had fevers, for example, or may have had seizures, can create behavioral problems, and you have to be aware of how to treat them.
Or flus, Dr. Mac, or flu. They say flu, influenza.
Yes.
Which can sometimes cause schizophrenia.
Influenza.
That's what I read in a book. Yes, ma'am. That's what I read in the abnormal psychology book.
Influenza.
Yes, ma'am. If the mother had flu while she was pregnant with the child, there's a high propensity that the child could develop schizophrenia. That's what.
Oh, you mean Ray's syndrome?
I don't know what the schizophrenia said. Abnormal psychology.
Anyway, but basically then, what I'm saying then, that things that you're talking about are known as teratogens, and I'm going to explain what teratogens are. That there are substances, and you can write now, teratogens are substances that cause birth defects. There are substances that cause birth defects in the fetus. There are substances that cause birth defects in the fetus due to exposure. I'm not done. Due to exposure to drugs, chemicals, and certain maternal or certain pregnancy difficulties. So the human brain is most susceptible to teratogens. Continuing, the human brain is most susceptible to teratogens. And from weeks 3 through 8 in the fetus, weeks 3 to 8 can have major structural damage in the brain. From weeks 3 through 8 in a fetus can cause major structural damage in a fetus. And you can have some, and I'm going to give you some examples of teratogens just for your knowledge. One is alcohol. So you may have a child with fetal alcohol syndrome, and it's irreversible. So a child who has that, you're going to have problems working with this child. Fetal alcohol syndrome. 2, cocaine is another teratogen. 3, nicotine. 4, HIV/AIDS is another teratogen. 5, malnutrition is another one. 6, rubella is another. And lastly, 7, stress is another teratogen.
What is that, Dr. Mark? Stress?
Stress, yes. Yes, that stress in the mother can create hyperactivity in the child, irritable bowel syndrome. It can cause that. So those are teratogens. All right. Are there any other questions? You want us? I will continue. Matt, yes.
Yes. Eileen made a comment. She said if the lecture for treatment will not be done until Monday, then group 1 will be at a disadvantage if they are to present on Monday.
No, I'm not expecting people to present on Monday.
Monday is the 18th.
Is it the 18th?
Yes. Yes,
oh my God. Where's my? I'm thinking it's. I don't know where my head is. Oh dear.
There.
Unless Dr. Martin, we're going to have class for Wednesday, then we can keep the presentation till Wednesday then.
We have a presentation on Wednesday.
It's a lineup, Victor. It's one after the other.
Yeah, if Dr. Mark has to deal with play therapy before the presentation, I think I'm just.
All right, we have to make a consensus. I don't know why I thought Monday was the 11th. My brain is. I think I'm old. I'm getting old.
Dr.
I drink too much wine. I think I drank too much wine and eat too much lobster.
But Dr. Mark, you're not correct. Monday was the 11th, but the Monday that gone.
Yes, I think I have a senior moment. I eat too much lobster.
Yeah.
Too much seafood, man. Your thyroid gland, Dr. Mark.
Yes. No, that's all right. Lobster season is here, so I'm going to enjoy the lobsters. They only come once a year.
What's your iron level, Dr. Mark? What's your iron level?
I'm okay. On a serious note, I didn't realize. Okay, so what are we? Okay, don't worry. Ladies and group 1, don't worry. It's not going to impact you. Just research the treatment intervention. Don't worry about it, because we're going. What I'm going to be doing is doing how to interview children. It has nothing to do with the presentation. So don't worry about that.
How long should the presentations be then, Dr.
I believe it's up to you. It's about 45 minutes to an hour.
Oh, so it can be 43 hours then?
No, she said 45 minutes to an hour.
Oh, just checking.
No, not 3 hours. No.
No, because she said that it's up to us. There's no,
what I'm saying to you is that we need,
like Marshall have plenty things.
Okay, what I'll do, I will wrap up this on Monday. I will do this first, that we can have people to present we may need to. I'll try to do as much as I can with this. Start treatment with the treatment, at least that, and then we can have one presentation, because it's going to be problems with 2. It's not going to work. So 1 is important. We can do it before, and then we do the lecture, or we can do it whatever you prefer. That I don't know. What do you prefer, Miss Michelle?
The lecture.
Michelle? The lecture first?
Yes, ma'am.
Okay. So what
the lecture first.
Roina,
where are you responding?
Dr. Mark, the presentation pause before the lecture.
Answer for your group.
Michelle. Dr. Mark, presentation pause.
Michelle is in group 2.
First, I'm asking Eileen, as she's the leader, but for my preference, I would say presentation first, get it out of the way, and then the lecture after. But I'm waiting on her response.
Okay.
Yes, that's a group thing.
Yes.
All right. Let me know by email, please. Okay. So we'll be starting treatment on Monday, God willing, and I'll wrap up on this dimensions of diagnosis with children. I'll wrap that up on Monday.
Will you do cases in that class?
Yes, I plan to, Miss. Yes, I plan to. In fact, I'll send it. I'm going to send the case to people that they can see it, and we can come to discuss it. And I'll tell you what to. Yes, we'll do that.
Okay, Dr. Matt, before you leave, as you had started out the class, you had made requests of us within the chat, and I would like to say that as for next week, when none of us will be on the link, that for those who are coming on listening via YouTube, and for those that are going to be coming on, that we are going to really, Dr. Bact had asked that whenever she makes a point, sometimes she might be moving on to something else and might have forgotten where she was. So it is up to those who are on the chat to kind of bring her back to where she is at. And so we are going to be asking those coming on next week, this is a treatment class and a case class, a very important class, if, just to remember, when there's a moment of strain, to just kind of gently bring Dr. Matt back, as she has requested that we do. because you know she's brilliant and she has a lot to say, so we have to ensure that we keep everything in check, right, Dr. Mack?
Thank you. Well, that was nice of you.
Thank you very much.
Also, Michelle.
I'll give you.
They could look or questions.
I will send you a glass of what you call. I'll send you a glass of portobello wine across over the internet. All right?
Yes, Doctor. But I think yes, Dr. Mack. Thank you. I think what Nordia is also saying is that they must the comments, Nordia. That's what you're going to say.
The questions and the comments, if they could just look out for them for us. Can you hear me?
Yeah.
Okay.
Look out for them.
We did well this evening.
Look out for what?
I'm just adding that. I'm adding that if they could look out for our questions and our comments.
Oh, okay. Yes. In the same way that we were attentive today.
Right. Thank you.
That's how it's generally done.
Hello, Jane.
Dr. Mack.
Yes.
Eileen said she would prefer if Group 1 do the presentation first, and the lecture can come after.
All right. Well, we do that sharp on Monday.
Okay. What time we get on? 6 o'clock?
Mr. Nyame will tell us. Ask Mr. Nyame, what time should be on? Mr. Nyame?
Good job.
It's 6 o'clock. Once it's 6 o'clock that we had agreed on?
Yes, I think it works better when we all get at 6 and then we get time for people to come on.
We have a little challenge.
Okay.
We have a little challenge. If you're going to have whoever is in Group 1, we'll have to take precedence to be in the chat, the live chat.
Yes.
So even if they're here now, they would have to be there as well for the chat session at least.
That's not a problem. That's
okay.
We're gonna have to juggle that in terms of those who were not on YouTube this time.
Yes, you just scramble the other 4, but just make sure the group members are on each time.
Well, as long as there's a consensus, that's fine, Lenny.
Totally. That's a given. That's a given.
What was that?
Don't stress yourself. That's a given.
It is a given closure. Just rotate the others and ensure that each time all group members are present. Whichever group is going to be presenting.
Because we are going to be presenting on the 20th, which is the week up, which is 2 days later.
Okay.
Oh, okay. Before you go, on Monday, just to underscore, we'll be looking at the case conceptualization method and Child Care Act. However, there's a lecture to cut down time. There is a lecture on Child Care Act on the website. Please avail yourself of that lecture on the Child Care Act.
Child Care Act.
Yeah, in other words, it's on when week 3 is open, Mr. Nyame, it's there on week 3. Please avail yourself of that module. I did it last year, but I don't want to go to the Child Care Act in the class because of time constraints.
Okay.
Mr. Nyame, so you are responsible for viewing that chat on the Child Care Act.
Is this something that I'm going to need to know for the exam, Dr. Mack? Just a question.
Very important question.
Just a quick question. Just a very quick question.
I'm not
haven't
certain yet.
That far. Okay.
I'm preparing the exam already, but I'm not certain yet. But more than likely, but you need to watch that clip. We'll be looking at treatment case conceptualization method on Monday, and we'll continue. And I'll bring a case for you to be able to get some practice. I'm gonna send it over the weekend to Mr. Nyame that you can have it, that you can look at it and come with it on Monday. All right?
Okay, Dr. Mack. Anyway, Dr. Mack.
All right, it's way past my bedtime.
Yes, ma'am.
Okay, thanks, Dr. Mac.
Bye, and thanks.
Okay, bye-bye.
Have a good weekend.
Bye.
Yes.
Good night.
Bye-bye.
Take it easy.
Have a good
Good
weekend,
night.
Dr. Mac. Night, everybody.
Bye-bye.
Take it easy. Bye.
Bye, Nadia. Don't send any greetings now.
Night, everyone. Night.
Good night.
Night,
Victor.
Pat.
Victor. Victor.
Victor, go to sleep.
He's gone. Okay.
Night.